All right. Welcome everyone to Department of Medicine Grand Rounds. Oh, I think I have, sorry if there's an echo. There's the EUH classroom behind me. But thank you all so much for joining us today. We have three superstars from our Division of Pulmonary Critical Care and Allergy to present pulmonary updates to us today. And so we will have a series of three presenters. I'm going to go ahead and do their introductions and then hand the mic over to them. So we'll start off with Lucian Martz, who is an assistant professor of medicine. He's a clinician specializing in ILD with an emphasis on sarcoidosis and aims to improve the understanding of disease pathogenesis and patient care through his translational and clinical research. We also have Wendy Naveau, assistant professor of medicine. She's the clinical director of Grady Hospital's Allergy and Asthma Center. She's an active clinician at Emory University's Asthma, Allergy, and Immunology Center, where she specializes in advanced asthma and immunological diseases. And her research areas of interest include identifying new therapeutic targets for asthma treatment, development of non-invasive wearable devices for the detection of small airways dysfunction, and evaluating the effects of environmental health on asthma outcomes. And then finally, last but not least, we'll also have Aaron Trammell join us, another assistant professor of medicine, a clinician scientist focused on advancing the evaluation and management of pulmonary hypertension through expert care and clinical and translational research. So we're very excited to have a broad spread again of superstars in pulmonary medicine to give our updates today. And I am going to hand the mic and the screen over to you, Dr. Martz.
Excellent. Thank you so much. Let me see here. All right. Can everybody see my slides? Fantastic. All right. Well, thank you again for inviting me out to talk about something that I'm passionate about. So without further ado, we'll talk about pulmonary sarcoidosis. Just one disclosure. So I'm the site PI for the phase 2 and ongoing phase 3 trial for one of the new investigational drugs for sarcoidosis, efzofitimod, sponsored through A-Tier Pharma. However, I received no direct funding and A-Tier is not paying me to talk about this. So by the end of the talk, my hope is for you all to be able to recognize some historical barriers and describe recent promising advances in both the diagnosis and management of pulmonary sarcoidosis. So if you're anything like me at the beginning of my training, you have a general sense of what sarcoidosis is, but it's somewhat nebulous, right? Is it infectious? Is it autoimmune? And so I think this definition kind of distills it to its core elements, which is a systemic, meaning it can affect any and all organ systems, inflammatory disorder, right? So both the adaptive and the innate immune system are involved. Of unknown etiology, characterized by formation of non-necrotizing or non-caseating granulomas in affected organs. This is just a picture of the classic sarcoidal non-necrotizing granuloma. You've got the epithelioid histiocyte or macrophage core surrounded by lymphocytes. Lungs are most commonly affected, right? 90% of the time, your patient is going to have pulmonary sarcoidosis, which is generally why most individuals will see a pulmonologist at least once in their lifetime. And much like most disease pathogenesis, there's two hits, right? So there's some form of genetic predisposition, genetic priming. MHC class 2 molecule alleles play a large part in that. And then an antigenic stimulus. And there's a number of different proposed antigenic stimuli, and nobody knows exactly what they are. And to be frank, there's probably a number of them. Just a little history. We know that this is an antigenic priming due to the Cavine test. So this is a test where you took homogenized spleen from a patient with sarcoidosis and injected it into the skin of somebody that was concerned for sarcoidosis. And if there was a granulomatous reaction, you had your diagnosis. And it was a great test. But in the age of infection prevention, that's definitely gone by the wayside. A few potential causative antigens that we think may be related to infection, right? So that we've identified genetic material from Mycobacteria tuberculosis, non-tuberculous mycobacteria, as well as C. acnes. The ACCESS trial, which was the largest prospective trial, proved that inhaled environmental factors, things like microbial bile aerosols and inorganic materials may play a role. And then finally, autoantigens. Bimentin is thought to potentially play a role in predisposing to sarcoidosis. And this is a diagnosis of exclusion, right? It's never definitive, right? So we talk in provisional diagnosis and percentages. We think greater than 90% is a high probability, and then less than 90% moderate probability or low probability. So because we need a biopsy and because it's a never a definitive diagnosis can be challenging and it can be prolonged, right? So the first thing you need to have is a compatible clinical radiographic presentation. So there's certain demographics that can be associated that we commonly see in sarcoidosis, right? African Americans more commonly seen than Caucasians, females more than males, age kind of late, early to middle age, anywhere from 30 to 60 years old. There's some physical exam findings that we'll talk about in just a bit, and some imaging findings that we'll talk about in just a bit as well. But this is a great mimicker, right? Exam findings and imaging can be seen in other disease processes. And so if you have this compatible presentation, then the next step is a tissue confirmation, right? We absolutely need a biopsy to feel confident in a diagnosis, right? You need to prove that these non-necrotizing granulomas are present. And if all you have is pulmonary disease, biopsy can have inherent risks associated with it. There's risk of bleeding, risk of pneumothorax, risk of respiratory failure. Thankfully, there are a few select populations that we don't commonly see in the Southeast because it's more in the Scandinavian descent. But Lofgren syndrome, so that's a combination of fever, hilar-adenopathy, erythema nodosum, ankle arthritis. Hereford syndrome or uvea parotid fever, so uveitis, parotitis, fever. And then lupus pernio, which I'll review in just a bit. So once you've obtained your tissue, you feel confident in the diagnosis, you need to exclude other granulomatous processes. And there's a slew of other things that can mimic sarcoidosis and have non-necrotizing granulomatous features. So tuberculous, non-tuberculous infection, fungal infection, and then non-infectious etiology. So people that work in areas where beryllium is common, drugs, malignancy, aspiration, all of these can produce granulomas. And so you can imagine that it may take some time to get a diagnosis, and that may delay treatment, right? It takes 3 to 12 months for a definitive diagnosis in upwards of 75% of patients. So talking a bit about clinical presentation. So patients where you may be concerned for sarcoidosis, they have nonspecific symptoms, right? Dry cough, shortness of breath. Chest pain is fairly frequent. You can see endobronchial cobblestoning on bronchoscopy. And then they may have restrictive and or obstructive lung disease or normal PFTs. In fact, normal PFTs are the most common. Extrapulmonary symptoms are fairly frequent. Fatigue, probably the most common symptom of sarcoidosis and also the most challenging to treat because it doesn't usually respond to what we typically use for treatment. You can get a rash, uveitis, and I just want to highlight a few pictures here. This is from a New England Journal Review article. So this is kind of a papular rash that we commonly see in sarcoidosis, though certainly not specific to it. This is that lupus pernio rash, that kind of maculopapular rash that I was referring to that is a little bit more specific for sarcoidosis. Uveitis, lacrimal gland enlargement. This is the endobronchial cobblestoning and then facial nerve paralysis. On chest imaging, frequently we see symmetric hilar subcarinal lymphadenopathy. You can have upper lobe predominant perilymphatic nodularity. This is the galaxy sign where you have this kind of coalescence of all these nodules forming these consolidated changes, again, upper lobe predominant. And then finally, if inflammation is left unchecked, there's can lead to scarring. So we would love to have some non-invasive biomarker of disease detection and monitoring. Unfortunately, there's none that's really good that's out there. So the most frequently used biomarker is angiotensin converting enzyme, or ACE. This is macrophage derived, converts angiotensin 1 to 2, thought to correlate with granuloma burden, but it's not very sensitive. It's only elevated in around 60% of acute and 10% of individuals with chronic disease, and it's also nonspecific. Caution in measuring this in individuals with ACE inhibitors, it can be low. And as I mentioned, the sensitivity and specificity are quite variable and fairly low. And so this really has no role in diagnosis. Sometimes I'll check it as a baseline and then serially monitor if I have somebody with new symptoms. And if it's elevated in follow-up, I may think that that's more suggestive of symptoms due to sarcoidosis than not. But that's really the only role that it has. Soluble interleukin-2 receptor, this is a T-cell derived marker of Th1 activation. A little bit more sensitive and specific than ACE, and I do, again, frequently check this initially and for monitoring, but not for diagnosis. Because it's also nonspecific, it's secreted in the kidneys, so it can be elevated in individuals with renal disease. And again, the sensitivity is a little bit higher, but certainly not high enough to come up with a diagnosis. And so we've searched far and low for different antigens, different biomarkers, and Hanudi's group is probably has done the best job at identifying one of these. And so this is one of the updates that I wanted to talk with you about. This is they created a T7 phage display library from bronchoalveolar lavage samples as well as white blood cells from individuals with sarcoidosis. And what they identified was two novel antigens that were able to discriminate sarcoidosis from other groups. Now, these antigens were homologous to, not the specific protein, but homologous to cophilin-1, which is a protein necessary in actin depolymerization, as well as chain A on the methionine aminopeptidase. This is an enzyme, metalloprotease, that's necessary for cleaving methionine from growing proteins. As I mentioned, these were what we call out-of-frame peptides. These were just epitopes that they identified, and they termed them as neoantigens, and the names they gave them are cophilin-mu and chain A. So to follow this up, they published a paper in the Blue Journal that was just recently published of 386 patients, a little over half with sarcoidosis, in comparison to healthy controls in those with TB and lung cancer. And what they found was that there were significant differences and antibodies to cophilin-mu and chain A that were able to discriminate sarcoidosis from control patients. The test performance was fairly robust. Sensitivity greater than 90%, specificity approaching 90% for cophilin-mu, as well as for combined using both cophilin-mu and chain A. And so the thought is that these may be useful adjuncts for sarcoidosis diagnosis. And certainly this is not the end of this story. We need to study this in a larger population, in particular patients that are undergoing evaluation for sarcoidosis and compared to the gold standard of biopsy prior to making this ready for prime time. But it's certainly exciting. So just to transition into management, immunosuppression is the mainstay, but treatment is controversial, right? Glucocorticoids are generally first-line therapy, and there's increased risk of infection and other side effects. And a large minority, some say majority, about 30 to 60% of patients with pulmonary sarcoidosis have a benign course. They're asymptomatic. And so I generally use Wells' law as an indication for treatment. Athol Wells, he is one of the kind of premier sarcoidosis specialists out of the Brompton. He really said there's only two indications. One is impairment in quality of life, right? Symptoms attributable to sarcoidosis. The other is fear of danger, right? And this is a little bit more nuanced, but this is progressive loss of lung function, baseline severe impairment, or life-threatening organ dysfunction. I'm not going to go into great detail with this slide. This is from the ERS Clinical Practice Guidelines for Management of Pulmonary Sarcoidosis, but just wanted to highlight again, prednisone, first-line therapy. Second line is generally methotrexate. If you can't tolerate methotrexate for whatever reason, azathioprine and mycophenolate are appropriate. And then finally, if you're continuing to have progression of disease, we use Remicade or another anti-TNF. Somewhat of a busy slide. The only thing I wanted to highlight, this is from that same paper, the summary of evidence for first-line therapy, right? Glucocorticoids, undesirable effects, fairly high. Certainty of evidence, very low. We have very, very limited evidence looking at treatment of sarcoidosis. And there's a lot that we just don't know. And I think that this slide highlights this as well, where you've got various disease processes on the x-axis and number of investigational drug studies on the y-axis. And you can see that sarcoidosis here is really at the bottom of the pack, right? So there has not historically, even though we've recognized this disease for over 100 years, been a lot of research effort into looking at investigational drugs for it. So efzofitimod, this is one of the drugs that I wanted to talk about, really the only targeted therapy that's being studied in a phase 3 trial right now. This is a histidyl synthetase analog that selectively binds neuropilin-2. This is a receptor that's increased in activated immune cells, especially in sarcoidosis, thought to decrease inflammation and fibrosis in preclinical studies. And in the phase B1, in the phase 1b/2a RCT, we found that it was fairly well tolerated, right? Just a little bit more cough, a little bit more headache in individuals on study drug as compared to placebo. And their secondary outcomes were quite promising as well. The main thing I care about, that most sarcoidosis specialists care about, is how do we get individuals off of steroids, off of prednisone, right, with all the harmful side effects. And there was about a 12% reduction in the high dose of efzofitimod. This is not statistically significant, but there was certainly a trend towards improvement in lung function in the high dose group as compared to placebo and low dose groups. And it paved the way for the EFZO-FIT trial. So this is literally the first 3 investigational interventional drug trial in patients with pulmonary sarcoidosis ever. And I think that's telling, right? I think that the phase 2 trial paved the way for this, and my hope is that more investigational drugs, more phase 3 trials will come out, and that does seem to be the case, right? I'm not going to Unfortunately, this is a little bit out of the scope of this presentation, but there are a number of phase 2 investigational drugs that are looking at sarcoidosis that my hope is can make it into phase 3. So in summary, diagnosis can be challenging, frequently delayed due to the need for tissue confirmation of non-necrotizing granulomas, though anticophilin mu and chain A antibodies may serve as useful biomarkers for disease diagnosis, though study in a larger population is warranted. Management is nuanced. There's a heavy side effect burden from glucocorticoids, and my hope is that results from recent investigational drug trials will reshape that treatment landscape in the years to come.
Thank you so much, Lucian. And Wendy, I think you're getting ready to go.
Yep.
Looks like it. Sounds good.
Okay, I'm ready. All right. So I'm going to give a brief update on the Global Initiative for Asthma 2024 guidelines. And I'm going to take a focus on a case that I saw in clinic and how to apply this to some updates for cough variant asthma, but also use this as a way to just review some of the maintenance and reliever therapy guidelines, because I feel like there's a lot of confusion still and how this is being prescribed. And when we see this in pulmonary clinic, we kind of have to redo a lot of the prescriptions and re-educate patients, because this can actually be a very helpful treatment, but we have to use it the correct way. So I have no disclosures. My objectives of my talk is to review asthma pathophysiology and to define what cough variant asthma is. We've reviewed some current GINA 2024 guidelines for the identification and management of asthma, and also kind of use this case to show how we can apply this updated ICS formoterol MARC guidelines to our patients. So in brief, asthma is a chronic inflammatory disease of the airways that's defined by reversible airflow limitation and airway hyperresponsiveness. Symptoms can include a combination of wheezing, dyspnea, chest tightness, cough, and exercise-induced bronchoconstriction. Now, how it develops really is dependent on airway inflammation and how it interacts also with smooth muscle cell dysfunction. So after a patient gets infected with a URI, or say there's some inhalational exposure at the level of allergen exposure, or there's some intrinsic inflammatory signal, this will cause epithelial damage and inflammation and will release inflammatory cytokines into the airway that will then promote further cell mediator release, cell proliferation, mucosal wall damage, or edema, epithelial cell damage, and basement membrane thickening. These cell mediators can then crosstalk back to the smooth muscle cells, which can cause bronchoconstriction, bronchial hyperreactivity, smooth muscle hypertrophy, and cell mediator release, which again crosstalks back to the airway. And this can lead to symptoms and exacerbations in patients over time if this goes unchecked. This is a nice schematic that I found in Nature Reviews that goes over inflammatory asthma phenotypes. So we're really getting down to precision-based medicine and asthma that asthma is not all the same, and it can definitely vary based on a patient's age, and it can vary throughout a patient's lifetime. So if you go to the far left, we see that most of the early onset asthma we think about in childhood, we think about allergic asthma, exercise-induced asthma, although we can also see this present in our adult patients. As you get a little bit older in your adulthood, you'll see things pop up like aspirin exacerbated respiratory disease, eosinophilic asthma. These are called the T2 asthmas. So this is where you have eosinophilic inflammation, IL-4, 5, 13, these types of cytokines that drive that molecular endotype, or that type of inflammation driving that pathophysiology for that kind of asthma. However, as you go a little bit across the spectrum, there's also other non-T2 asthma endotypes as well. And that can be postgranulocytic asthma. We usually see this in older women. Sometimes you'll see obesity-associated asthma have like a Th17 or neutrophilic predominant inflammatory milieu, although I have actually seen my share of eosinophilic patients with obesity associated asthma as well. So it's a fairly complex thing. And then you even have viral associated asthma, smoking related asthma, COPD, and the list goes on and on and on. So clearly, the more we learn about it, the more complicated it becomes. So what about cough variant asthma? How does it fit in this context? Well, essentially, cough is the sole or predominant symptom, but it doesn't mean your patients can't wheeze. At some point, they might develop that, but that's not their predominant symptom. Usually they have a dry cough, but sometimes it can be semi-productive. It's about 10 to 40% of the chronic cough cases that you see come into your primary care clinic or get referred to ENT, GI, or to pulmonary clinics is actually related to cough variant asthma. And although we think about asthma as having variable airflow limitation, most of the time your cough variant asthma patients will have normal spirometry. So that's an important thing to know, because if it's normal, sometimes patients will be told, oh, you can't have asthma. And then that will beget a delay in their time of diagnosis and can have a lot of comorbidities that develop as a result of that delay in diagnosis. So one thing that should also be emphasized is that all asthmatic patients, including your cough variant asthma patient, have positive bronchoprovocation studies. So that should be a part of the workup. And also this asthma, this type of asthma is very heterogeneous as well. So it's just like that previous slide that I showed, there's different types of clusters, different types of phenotypes, endotypes, even for cough variant asthma. And this was actually an interesting cohort study that was looking at groups of patients with cough variant asthma in China. And they actually found that there's different clusters of phenotypes. For instance, maybe female predominant late onset presentation, normal lung function in one group. And then they found that some people were more nocturnal coughers. They had more symptoms at night. But then, they had more T2 high inflammation when you did a little more investigation into their endotype. And then you had other people that had strong family history, maybe some impaired lung function. And when you did transcriptomics on the sputum, you can even divide up these clusters even more and show that some of them actually have differential inflammatory signals. Some are T2 high, some are T2 low. So again, it gets to be a very complex thing that becomes important for us as pulmonary doctors when we're seeing these patients in clinic, or when we have to eventually endotype them further for more precision-based biologic treatments, when we're escalating them up the GINA guideline steps, when we're putting them on therapies. This schematic here, I think, is very critical, because we often see chronic cough as a common primary care complaint. And also in a lot of our specialty clinics. So it's good to familiarize yourself with the algorithm. So taking an excellent history, occupational, environmental, has your patient traveled? What medications could they be potentially taking? Do they smoke? Any other inhalational exposures? Once you go through that physical exam, maybe get some imaging, you're going to come up with your four most common causes to consider. And that's always going to be upper airway cough syndrome. So you think about chronic rhinosinusitis. It could be allergic, non-allergic. Asthma sits at the top of this list. Then you have things like, Then you have things like non-asthmatic eosinophilic bronchitis. And then you have GERD. And after you kind of figure out what the most likely candidate is, you try some empiric therapies, 4 to 6 weeks. If a patient's not getting better, you kind of change your strategy a little bit, and eventually you'll send them over to us. So I think we can kind of use this schematic or that algorithm for working up a patient that got sent to me with a 6-month history of dry cough, because I think this really does show you how to work up cough variant asthma, and especially using the new updated guidelines. So I have a 21-year-old female. She has a history of GERD, chronic rhinosinusitis without nasal polyps, who came in with 6-month history of a cough. It's present day and night with increased early AM awakenings a few times per week. Her cough is exacerbated by exercise. She has seen her primary care doctor and basically had her PPI regimen intensified, but no improvement. Also had her nasal steroid combined with a nasal antihistamine and also no improvement. Chest x-ray was clear. She had negative allergy testing and she was referred over to me. And this is her spirometry. So essentially unrevealing, looks normal flow volume loop. Her nitric oxide testing in the airway was normal, and her spirometry is normal. So the question becomes, with normal spirometry and normal FeNO or fraction exhaled nitric oxide, does this rule out asthma in a patient with chronic cough? And I really want to emphasize to this group, no, we need to keep on working up this patient further to make sure we can identify asthma or not. So this is the updated diagnostic flow chart that came out in GINA in 2024. So they've been updating this every year. And if we use my patient as an example, it's pretty straightforward how to work up this patient. So in the case of my patient who came in, are her symptoms typical of asthma? And I would say yes. She had nocturnal awakenings, a dry cough. She was exacerbated by exercise. These certainly could fit those features. Does the history exam support diagnosis? I would say potentially. So I'll just say yes here. Is she taking inhaled corticosteroids? The answer is no. Does she have severe impairment where I have to start empiric therapy right now? No, I think I have time. Is there spirometry available? Yes, we did it. Was there variable expiratory airflow limitation confirmed? The answer is no. So over here, that's where we're really pushing more in GINA to recommend recommend providers to do more ancillary testing to really work up whether asthma is there or not. And if your patient, say for instance, was already on an inhaled steroid, wean them down, recheck them in about 4 weeks, get them off the inhaler, retest them. Because, sometimes when you're put on empiric therapy and it's not working, maybe there's a reason. And maybe you're blocking the test from showing you something, or maybe not. Maybe it's just not there. So it's just more of a stepwise approach. We really have to be encouraging our providers. So what the ancillary test is would be the bronchoprovocation challenge, or in this case, a methylcholine challenge. And GINA really defines a positive bronchial challenge test as a fall of baseline in forced expiratory volume in the first second of greater than or equal to 20% with standard doses of methylcholine, which is the one that we commonly use. Right? Certainly, there's other tests that we can use. For sake of time, I'm not going to get into that. Here's an example of the methylcholine challenge. So basically, the methylcholine challenge is where we give people inhaled saline as a baseline, and then you will give them increasing doses of methylcholine to see if it can cause bronchoconstriction and a fall in the FEV1. You keep on giving them increasing doses until you hit that 20% or greater fall. And then you basically reverse it with a bronchodilator. And if a patient doesn't have a response, there's no airway hyperresponsiveness, and the negative predictive value for asthma, ruling it out, is pretty high. So just an example, a patient that has like a fairly robust airway hyperresponsiveness response to methylcholine is shown on this far left, moderate's kind of in the middle. And then if you have mild, just be aware that sometimes you may see that in allergic rhinitis patients, but you may not actually see it may not actually be true asthma. So you have to have the correct clinical context in how you're interpreting that. So what about our patient, and how do we interpret her study? Well, interestingly, when the patient inhaled saline, she already had a 24% drop in her FEV1. So she was already having airways hyperresponsiveness, even to her internal control. But after the first dose of methylcholine, she actually had a 21% drop. So she's already positive for airway hyperresponsiveness very early on into her methylcholine challenge. And so we gave her a diagnosis of cough variant asthma based on all of her features and based on the test. So the question becomes, what do you do with her and how do we apply this to the maintenance and reliever therapy management guidelines? So this gets me into the next section, what's new in GINA 2024 for asthma management. And I think that what's really important is really to think about what are the overarching goals of GINA. It's really long-term symptom control. We want fewer no asthma symptoms, no nocturnal disturbances. We want patients to be able to engage in physical activity in a healthy way and not be impaired. We really want to minimize exacerbations to provide or as a way to promote and sustain improved lung function, really to decrease the amount of times patients need oral systemic steroids and try to avoid side effects from medications. And I can't help but say this enough, just doing an asthma control test score is not enough when you're checking someone's symptom scores for each visit. Really, you have to get down to the granular level of knowing what are your patient's true risk factors. Do they live in a home with mold? Is there somebody that's smoking? Are they doing, recreational drugs? What are their allergic triggers? What type of modifications have they made to their home? So that way you can do on an individual basis risk modification with them to prevent severe complications in the long run. So this is an example of the updated guidelines for inhaler management. And so there's two tracks. Track one is actually known as the maintenance and reliever therapy. It used to be called SMART, single maintenance and reliever therapy, but they changed the acronym. Track one is actually preferred, and this is where you're using an ICS combined with formoterol as your rescue inhaler and your maintenance inhaler. So you're trying to get people to be more adherent by using one inhaler. And there's actually data that backs this. Track two is not preferred. This is what we've classically been doing, where you have patients who've been regularly on an inhaled corticosteroid or on a combination ICS-LABA. That is not ICS formoterol. And they're still using on-demand short-acting bronchodilator like albuterol, but they're trying to push more towards a short-acting anti-inflammatory budesonide albuterol combination exchange here. So we'll get into this in just a few moments. So what is the new evidence that really supports why we should be pushing towards track one? Well, basically because people do better. There was at least 4 randomized controlled trials, and there was a review that came out, or a meta-analysis in 2021, where they looked at asthma exacerbations that required steroids in patients. And the first thing they did in the novel START trial and the Sigma-1 trial, these were looking mostly at mild asthma patients, and they compared the rate of exacerbations that required steroids in patients when they used either on-demand budesonide formoterol versus albuterol. And there was another trial that looked at terbutaline as the bronchodilator. And what they found was a 55% reduction in severe exacerbations in those patients who actually use ICS formoterol group compared with the short-acting beta agonists alone. So essentially, they're doing better. And that when you compare standard of care therapies, an inhaled corticosteroid that a person uses every day, on-demand albuterol with it, versus a person who just uses on-demand formoterol and budesonide combination inhaler, we found that the people that use that combined formoterol budesonide inhaler actually have decreased trend in exacerbations requiring systemic steroid use. So that, again, once we see people doing much better in terms of exacerbations. And then there was other, measures that they looked at. What is the rate of hospital admissions, ER visits, urgent care visits? The data still shows that the novel START trial, the Sigma-1 trial, if you are using the on-demand budesonide formoterol combination inhaler versus albuterol or terbutaline, you have a 65% lower risk of going to the hospital, going to the ER, being admitted if you use that combination formoterol inhaler. And then the same thing, a trend is also seen, a 37% lower risk for going to the ER, being admitted, going to urgent care if you're using the on-demand ICS formoterol inhaler versus standard care, which is the ICS plus albuterol. So what this is really driving home is that patients are doing better with less exacerbations, less steroid use, less utilization of our ERs, less overall improvement in quality of life if they're using the ICS formoterol inhaler compared to standard of care. So how would one implement this? This is actually a nice, I think, way to kind of think about it, because right now there's some confusion. What do we put them on? What dose? The only formulation in in the United States right now that has formoterol with it that was studied is Symbicort or Brenya, or the generic of those, which is budesonide formoterol. A lot of times I'm seeing patients being put on 84.5 strength. That was studied in children. That was not studied in the adult trials. So actually what you should be prescribing is the 164.5 microgram inhaler to your adult patients. That's actually what was studied for these asthma patients in adults. And how you start it is if you have a patient that is basically hardly any symptoms and doing well, they don't need to be on everyday therapy, but perhaps just put them on PRN, ICS formoterol, budesonide formoterol, like say Symbicort, if that's on their formulary. And you can just have them take 1 to 2 puffs every 4 to 6 hours. Don't max out more than 12 puffs in a 24 hours if you're, have symptoms. And that could be a person that's fairly well controlled. But if you have someone that's having more symptoms, but maybe not every day, not waking up every night, you can play with the dosage. You can start them on a puff once a day to twice a day, and then still use 1 to 2 puffs every 4 to 6 hours on demand. And as someone is more symptomatic, you're just going to up titrate the number of puffs per day. Usually it's 2 puffs twice a day standing. And hopefully you can get another inhaler to give them for the on-demand use, because it gets a little trickier with our formularies or insurance, only allowing you to prescribe so many per month. And I'm going to get around to how we can potentially address that with this short-acting rescue anti-inflammatory inhaler that just got FDA approved. Another thing, just to give a little bit of I want you to focus on, is that the ICS formoterol is the only ICS LABA approved for use in the United States based on these trials. So you cannot do this with Advair. It does not work this way because salmeterol takes longer onset of action. And so really it's got to be something with formoterol. And another option you could potentially do, and this is what's been done in pediatrics, is you may consider mometasone formoterol or Dulera, because it has that same premise, because it's really that fast-acting, long-acting bronchodilator, the formoterol, that's in it, that's really been studied. And then you can use it using the same guidelines. And step 2 or track 2, this is again not preferred, but if you have someone who isn't having exacerbations but is fairly stable on their inhaler, you don't necessarily have to reinvent the wheel. The only thing that you might consider is that, say you have somebody who's on an ICS like Asthma, or you have an ICS LABA like Advair, you could potentially, instead of using albuterol, you could potentially try something like budesonide albuterol, which is now called Airsupra, which is made by AstraZeneca. There's actually data that shows doing that has superior effects compared to the albuterol as the rescue alone. And that was done in the Mandala trial, which I'll show briefly. And so I guess this gets me to close to the end of my talk, where how do we apply this to my patient? So I kind of go through the algorithm here. So you just figure out, where does your patient have their symptoms, how frequent? I would say that my patient has symptoms most days, or they're waking at night, but maybe once in a week or maybe a few times a week. You don't necessarily have to go to high dose steroids at that point. Maybe start her on a low dose ICS formoterol maintenance, and that would be budesonide 160, 4.5, 1 puff twice a day, maybe 1 puff every 4 to 6 hours PRN. So this was done just to show you how you can actually develop your asthma plan using the GINA guidelines. And so the last piece I want to just kind of bring up is, could albuterol budesonide be an effective rescue inhaler alternative in asthma? And this is important because, again, there's a lot of restrictions in how we prescribe in the United States because of insurance formularies and blocks that we have and how much quantity we can give per month. And there was the Mandala trial, which looked at albuterol budesonide fixed dose combination rescue inhaler for asthma. And basically, it was a multinational trial, phase 3, double-blind, randomized controlled trial, where they looked at the safety and efficacy of ICS-SABA, high dose and low dose, based on inhaled corticosteroid content, versus SABA alone. And they were adding this to people who were already stable on inhaled corticosteroid or inhaled corticosteroid plus LABA. And this intervention, was done for about 24 weeks. And then their primary efficacy endpoint was looking at time to first severe exacerbation and also looking to see if there's any increased incidence of adverse effects across the groups. And what they showed is that there's a higher probability and time and a quicker time to first exacerbation in patients who were given classic on-demand albuterol with their controller inhaler. And that those folks who use the higher combination rescue inhaler, the anti-inflammatory inhaler, actually had a lower probability and it took longer for them to develop an exacerbation. So essentially they did better. And there was no significant increase in adverse side effects when you actually did the statistics across the groups. So in conclusion, from the Mandela trials, basically shown that among patients with uncontrolled, and this was moderate to severe asthma patients already on controlled asthma controller therapies, as needed albuterol budesonide reduced the risk of exacerbation versus albuterol alone. It's relatively safe compared to other controller inhalers. It could be an alternative to MART in patients stable on other inhaler combinations. The intervention could provide more flexibility than the budesonide formoterol if there's insurance coverage limitations. And then there was a follow-up study called Denali that showed actual significant improvement in lung function in patients that use this combination rescue inhaler. And the FDA finally approved it in 2023 and it is available on various formularies. So to end my talk, in conclusion, chronic, cough variant asthma, one of the most common causes of cough. So please keep that in your differential. Remember, normal spirometry does not rule out a diagnosis of this and should require further testing. So bronchoprovocation, and obviously if that's being thought about, they need to see a pulmonologist or an allergy asthma provider. MART is considered an easier treatment plan to follow with better adherence because you got one inhaler and should be applied to all types of asthma, including cough variant asthma. MART therapy can help prevent serious asthma attacks and limit the amount of systemic steroids overall. However, due to the insurance limitations, alternatives, air combination inhaler like budesonide albuterol could potentially circumvent some of these roadblocks. And that's it.
Thank you so much, Wendy. And now to round us out today, we're going to pass the mic over to Aaron Trammell. I think he's getting ready to share for updates on pulmonary hypertension. Thank you.
All right. So hopefully you're seeing the right slides. There we go. So we've got about 15 minutes left, and I am going to take us home. So we're going to give updates on pulmonary hypertension. I don't think there are any relevant conflicts, but our PH program does participate in a lot of industry trials, which I'll kind of mention at the end. So we just want to review some of the latest advancements in diagnosis, classification, and treatment. I tried to cover everything, so to give you a better overview. To bring us up to speed, let's just take a quick refresher because pulmonary hypertension, pulmonary vascular disease is a little bit of a different space from the two more parenchymal and airways diseases that we've been talking about so far. So the clinical classification of PH is kind of where we start clinically thinking about pulmonary hypertension. And we typically break pulmonary hypertension down into these 5 groups. Pulmonary arterial hypertension being the prime pulmonary vascular disease that primarily affects the pulmonary vasculature and then has secondary effects on the heart. Group 2 pulmonary hypertension begins in the left side of the heart and affects the pulmonary vasculature. Group 3, it begins in the lung parenchyma with lung diseases like COPD or asthma, not typical asthma, but COPD or interstitial lung diseases. CTEPH is in group 4, where the pulmonary vessels are obstructed by residual material from clots, and group 5 is a catch-all for other forms of pulmonary hypertension. On the bottom there, you can see that group 2 and 3 are quite common, whereas the other forms are uncommon. I put this little handy 1, 2, 3, 4, 5 down at the bottom so we can keep track of what we're talking about as we go. So I wanted to cover the updated definitions of pulmonary hypertension. In 2022 and 2024, different groups who are in agreement with one another released guidelines on the definition and classification of pulmonary hypertension, and these apply to all the groups. So they have now determined that pulmonary hypertension is present when the mean pulmonary artery pressure measured at right heart catheterization is north of 20 millimeters of mercury. It used to be greater than 25, and in 2022 and then 2024, different groups decided that we should lower that. The main rationale is that the normal pulmonary pressures in healthy adults does not exceed 19, and if it does exceed 19 in observational studies, it's associated with worsened outcomes and symptoms. So we call it now pulmonary hypertension when the mean PA pressure is above 20. We break that down typically into whether that pressure is mediated by changes in the small vessels of the lung called precapillary pulmonary hypertension, where the pressure is all within and before the circulation of the lung. And in that, it's defined as there being a wedge pressure that is low, less than or equal to 15, and a pulmonary vascular resistance that's above 2. Whereas postcapillary pulmonary hypertension is defined as a wedge pressure that's elevated, so those pressures, at least some of the pressures, are coming from the left side of the heart. The pulmonary vascular resistance greater than 2 is a decrease in the pulmonary vascular resistance from earlier definitions of pulmonary hypertension. So overall, these definitions have become more lenient. Postcapillary pulmonary hypertension can be split into whether there's isolated postcapillary pulmonary hypertension, or if it's has a PVR of greater than 2, there's combined postcapillary and precapillary pulmonary hypertension. And that's really all I'm going to say about that particular piece, but there are some nuances in there. Now that we're updated on the definitions, I wanted to take you through an observational study really designed to look at redefining pulmonary hypertension, because we've been using those groups since the 1960s, and they've changed a little bit, but with the advent of newer technologies and laboratory techniques, there's been a lot of interest in understanding the backdrop of why patients get pulmonary hypertension. So this is a precision medicine initiative funded largely by the NIH beginning in about 2015, which is a study that enrolled patients with various types of pulmonary hypertension to try to understand clinically, hemodynamically, and molecularly what is going on in them. And the first report from that was this paper published in 2022, describing the clinical characteristics and survival across the spectrum of pulmonary vascular diseases. So again, like I mentioned, this is a large multi-center cohort study. In the study, all of the participants who were enrolled had pulmonary function testing, they had sleep studies, they had CTs of the chest, they had ventilation and perfusion scans, they had echocardiograms, they had right heart catheterizations. So it was quite an intensive phenotyping. Other studies in some subsets of participants included metabolomics, lots of genomics, and other, some patients had exercise hemodynamics. They enrolled patients across the spectrum of pulmonary hypertension groups, and they enrolled patients with confirmed pulmonary hypertension, and then something unique, they enrolled disease comparators. So if you had confirmed not pulmonary hypertension based on hemodynamics, but you had one of the conditions that would normally put you in group 1, 2, 3, 4, 5, they enrolled some of those patients as disease comparators. And that gave them a lot of ways of comparing the various groups, as well as enrolling about 100 controls. Now, they were originally planning to enroll about 1,000 patients, but they came up short on that enrollment. There were a lot of cool findings from this study, but I'm just going to highlight 2. This is a table from that first publication where they just described the type of pulmonary hypertension that the patients had. And they were assigned their pulmonary hypertension type based on expert opinion of the person that was enrolling them and consensus of an adjudication panel. But the folks that were enrolling these participants could also say, I'm classifying them as group 1, but they also have some heart disease, or they also have some emphysema. And so the interesting finding was that about 40% of patients that were enrolled in this very sort of well-characterized study in academic centers had mixed forms of pulmonary hypertension. So 40% had contributions of more than one clinical pathophysiology that was contributing to their pulmonary hypertension. And it's interesting to point this out because these patients are never enrolled in clinical trials. And in this study and other observational studies, they tend not to respond well to therapies and they have a poorer outcome. So it's important to know that this is a very common finding. They also described the outcome of the people with pulmonary hypertension. So here are the groups 1, 2, 3, 4, 5. And what you'll notice is that this is transplant-free survival. And these are persons without death or transplant. And you notice that this black line is above all the rest. So these are patients who did not do as well as the other groups who are clustered down below. And it turns out that this group is the patients with type 3, group 3 pulmonary hypertension due to underlying lung disease. This has been seen in other observational national cohort studies that patients with group 3 pulmonary hypertension actually have worse outcome. Group 1 pulmonary arterial hypertension is the one that we always worry about through the years, but over the years, more therapies and studies have been directed at this group, and these patients are actually doing better than the patients with secondary forms of pulmonary hypertension. So it's important to point out. Let's go to what those therapies are. So we're going to pivot to group 1 and focus on that for a second. There's this classic slide with the 3 pathways of therapeutic targets for pulmonary arterial hypertension. I'm just reminding you here. So it's the endothelin pathway, the nitric oxide pathway, and prostacyclins. These are all pathways that affect vasoconstriction in the lung, and there are targets, molecular targets and therapies that hit them. And all of the little therapies that you see down here have been proven to be effective in one way or another in PAH. Well, the new news is that there's a new target in pulmonary hypertension, pulmonary arterial hypertension. And this is a study from 2023 that was a phase 3 trial of sotatercept. And I'm going to show you what that is for the treatment of PAH. So it's only been studied and reported out in group 1 PAH patients. Sotatercept is a really interesting drug. It's a ligand trap. So in patients with pulmonary arterial hypertension, they are known to have pulmonary vascular remodeling, where pulmonary vascular wall cells, endothelial and smooth muscle cells, become hyperproliferative. And that occurs because some of the cell signaling, like growth differentiating factors and activins, activate these receptors, and the antiproliferative signals in pulmonary arterial hypertension tend to be blocked. So we're weighing way heavier on the proproliferative signals. Sotatercept binds to activins and growth differentiating factors to quote unquote rebalance the proproliferative antiproliferative axis, and in laboratory and preclinical models was effective, and so it's been studied in human trials now. And this was a phase 3 trial which enrolled 323 patients with functional class 2 and 3 symptoms, so moderate symptoms, persistent symptoms of PAH. They had to have confirmed PAH, and they were randomized to sotatercept, which is an injection every 3 weeks, or placebo injection every 3 weeks. As is typical for PAH, 79% of the patients were female, and interestingly, in this trial, these patients were heavily treated. So 61% of them were on triple therapy, so all 3 classes of those drugs, those pathways that I mentioned before, and 40% were on parenteral therapy. Most patients had a diagnosis of pulmonary arterial hypertension for a median of 8 years. So they were very well-established pulmonary arterial hypertension. And in a study that enrolls patients like that, it's just it's concerning that it may not show a robust benefit because these patients have been on therapy for a while. That said, it did show a benefit. The primary endpoint was 6-minute walk distance, and there was an improvement in 6-minute walk distance in this study. 6-minute walk distance is frequently used in pulmonary hypertension trials, and the benefit here was about 40 meters corrected for placebo. They had a lot of secondary endpoints, and this slide is too small to see them, but on a priori planning, they tested them hierarchically. So if the first was positive, they went on and did statistical testing on the next one. And essentially, the green arrows show you all the ones that were positive. It included stabilization of the disease and not progression, improvements in pulmonary vascular resistance measured by heart cath, BNPs, functional class, time to worsening, risk scores, and then some quality of life scores. So this was an overall very, very successful trial. And it's really exciting because it's a new therapy class in pulmonary arterial hypertension, which has potentially disease-modifying effects. But it was studied for 24 weeks, followed by an open label study, and there were some issues. It had an increase in hemoglobin, which was expected with this drug, and so patients who became polycythemic had to pause the drug. It caused new telangiectasias, which were not expected, but might be expected given that this drug probably changes vascular homeostasis, and patients had increases in bleeding. It's now approved for use. We have lots of requests for it, and we are excited to see how it performs in the real world. There's also, moving on to group 3 pulmonary hypertension. This is not so new news, but in 2021, there was a study showing an effective trial for pulmonary hypertension due to interstitial lung disease, so PH due to lung disease. In that study, they tried inhaled treprostinil and enrolled 300 and so patients, and compared it to placebo and looked at the primary outcome of walk distance and a lot of secondary outcomes. Suffice to say that the study was positive. It improved walk distance by about 32, I think, meters compared to placebo. And in secondary post hoc analyses, they've shown that this drug improves, reduces hospitalization from underlying lung disease and may stabilize the lung disease and prevent decline in the forced vital capacity from interstitial lung disease. So this is another therapy that we're using for patients with group 3 pulmonary hypertension. This one's been around a couple years now, but just know that it is out there. I want to move to group 4 pulmonary hypertension due to CTEPH and just give you an update on what we are doing at Emory. So there has been significant growth of the CTEPH program at Emory over the years, really since the COVID pandemic. And there's a lot of data that COVID hasn't really affected CTEPH, even though COVID causes a lot of thrombosis. But we've seen this much more commonly since COVID, and we've been dealing with it more commonly at Emory. So CTEPH is an uncommon complication of acute pulmonary embolism, and it really requires management by a multidisciplinary group of physicians, including folks with comfort in PH, pulmonology, cardiology, sometimes surgery, hematology, other groups. And it's important to identify CTEPH because it is curable, unlike the other forms of PH. Since 2020, during the pandemic, we had some issues getting patients to the centers that we typically referred them to. We did our first case of pulmonary thromboendarterectomy at Emory in 2020. And since about 2021, we've performed more than 75 procedures with good outcome. We've reported that in abstract forms. This is an example of some of the stuff that's removed from the pulmonary artery. And if you see this, it's not surprising that patients can't breathe when they have this. So this is a specimen. This specimen has a little bit of more distal disease, and this specimen has kind of mixed disease. But we want to identify these patients and get them to see us. We review their cases as a group and decide on therapy. A second therapy for patients that aren't surgical candidates is balloon pulmonary angioplasty performed by interventional cardiology. Again, hadn't been done at Emory, but it's an attempt to revascularize the pulmonary vasculature, and we've done this in about 30 patients now. They require repeated procedures, and I'll just show if this will play. And we're running short on time, so I'm not going to wait for it to play. But there is a lack of flow through a major part of the left lung in this case. And after revascularization, you can catch more vasculature in the lung. Patients have improvement in their symptoms and BMP levels after BPA. And it really does take a multidisciplinary team because these patients are being managed by different doctors. That team, and this is my last slide, includes our PH group, Dr. Fisher, our program director, myself. Hannah Oakland is a new faculty member. We have colleagues from interventional cardiology with Wissam Jabber and Mani Danishman in CT surgery, who's doing our PTE surgeries. And we're offering therapies, new therapies, and trials to patients across the spectrum of PH. Please give us a call if you have patients that you want us to see, and I will end there. Whew.
Thank you. Thank you so much for that comprehensive overview. And my goodness, those thrombectomy photos are impressive. In the interest of time, because we are beyond 1 o'clock, thank you so much to all of our presenters for this comprehensive review. Lots of cool new stuff and new ways to manage these diseases. We're going to adjourn here. And if anyone has any questions, you're welcome to stay on. But I think many people are logging off since we're a little bit beyond the time. Thanks so much, and we'll see you guys next week.